Welcome back. To end the day, our last session, we're going to hear from providers. We're going to hear what's happening in the exam room as that patient and the provider are making their decisions. And we're going to hear about it from a really unique perspective from both practicing providers, people that are deeply experienced and currently give care, and also from this perspective of being technology leaders. When I trained, I was trying to think if I had a single bit of education on all of the other challenges, all the other topics, all the other issues that go into choosing a specialty medication today and getting a patient successfully started on that. Certainly, I spent all my time thinking about the clinical aspects, but it's no longer the case. We can't, as a physician, you can't do that anymore. And so let's just start with a quick poll question to try to think about what are providers, what are physicians thinking about, what are they considering when they start a therapy? This is kind of an easy question. It's kind of a gimme. So we won't spend a lot of time on here because the answer is obviously all the above. These are complicated. These are complicated questions, and the physicians have to spend a lot more of their precious time and energy thinking about these topics. So I had the opportunity to host a panel. We did it a few days ago to try to fit this in between some of the physicians' clinical duties. And it was really a fantastic discussion. I've hosted many panels, and truth be told, this was probably one of the very best that I've ever done in terms of the insights and the dialogue and what I learned from my colleagues. So I'd like to introduce the panelists. The first one is Dr. Elana Oberstein, Senior Medical Director of Musculoskeletal at Modernizing Medicine. Next, we'll have Dr. James Hamrick, Senior Medical Director, Clinical Oncology at Flatiron Health. And last, we'll have Mark Siska, Chief Pharmacy Informatics Officer at Mayo Clinic. My honor now to host a panel with some of my esteemed colleagues. These three individuals represent a really unique perspective related to specialty medications. They're all clinicians. They have all done patient care or still do patient care. They're all leaders in health information technology. They build, design, implement, support technologies that improve specialty medications. And they represent tens of thousands of physicians at some of the most prestigious organizations across the country. So they have an incredible perspective of the challenges that are faced today. And so what we're going to talk about is really what happens in that exam room, what's going on in the provider's mind and the physician's mind as they're making that decision. We're going to talk about what's happening from the patient's mind in that exam room. And then we'll talk about how this impacts their business and what are some of the greatest opportunities that we together can collaborate on to make this journey for the patient even better. So with that, let's start with some introductions. Mark, why don't we start with you? Talk a little bit about your role, your background, and your organization.
Hi, Andrew. Again, thank you for having me participate in this event. My background is I'm currently the Chief Pharmacy Informatics Officer at the Mayo Clinic. So I oversee all the medication management supporting technologies across our enterprise. That would include not only our EHR related modules within our current Epic environment, but also some of the a great deal of the automation that supports med management. My background is vast. I've been at Mayo Clinic for about 41 years now, and in a number of different environments, primarily as a clinical pharmacist for many years, clinical supervision administration, and then somewhere around 1998, I decided to take at least at that point in time, it was just a limited part-time role in our EHR development. And now it's, for all intents and purposes, it really developed into a religion for me more than just a career. So the work I do is again vast, and it crosses all the different processes of end-to-end med management.
Great, thank you, Mark. Ilana, let's go with you next.
Hi, thank you so much for having me join this panel. My name is Dr. Ilana Oberstein, and I am a board-certified rheumatologist. I take care of patients, and I'm very familiar with today's topic, and again, grateful to provide insight. I also wear another hat, and that is the Senior Medical Director of EMA Musculoskeletal at Modernizing Medicine. Modernizing Medicine is a healthcare technology company. We create software in various specialties, and the goal is to improve the provider at the point of care being able to spend more time with the patient by providing software, not just electronic health record software, along with patient management software, really end-to-end solution, including also analytics, to really help doctors and providers at the point of care spend more time with the patient, and take away some of the administrative burden that goes along with documentation. So I wear both hats and very happy to be here.
Thanks, Ilana. And James?
So much, Andrew. It's great to be here. And so like Elena, I'm a physician, but I wear a couple of hats. I am a board certified medical oncologist and was in full-time clinical practice up until about 2016. Very much pride myself on being a general oncologist, seeing sort of the gamut of oncology patients. For about the past 5 years, I have also worked at Flatiron Health, which is a technology company that builds software for clinicians, specifically people that take care of cancer patients. And so, like Dr. Oberstein, I spend part of my time in the clinic with patients where I prescribe specialty medications and see how those workflows work, and how that works for patients and other stakeholders in the practice. And then in my time that I spend at Flatiron, we work, as Dr. Oberstein said, on solutions that try to help the technology to get out of the way of the clinician and the patient so they can have a very human interaction, but also, of course, carry out all of the things that are required from a technology and documentation and ordering standpoint to make sure that they get the best care that they can. So really looking forward to our discussion today.
Great. Well, thanks, all of you. Mark, I'm going to start with you for the first question, and please, James and Ilana, chime in afterwards. Mark, you've had, as you said, a vast experience. You've seen so many changes in healthcare over the years. Talk a little bit about the changes in specialty medications. What have you seen over the past few years or so? Where do you think it's going? Where is it getting better? Where is it getting worse and more challenging?
Well, it's a great question, Andrew. We just are currently involved with our departmental strategic planning process, and we're looking forward to our 2030 plan and really looking out the next 5 years. And when we started looking at that, we really identified 3 key challenges that we really are going to face in the next 5 years. Obviously, the increasing cost of medicines, the specialty pharmacy market, I think, is another key piece to that. And as part of that, the piece that I'm actively involved in, and more so than many others in the department, is delivering care that is supported by advances in some of our technologies. And so I think it's safe to say after 41 years, I can say that I've seen the evolution of the specialty pharmacy, considering they didn't exist when I started practicing in the late 70s. So in some respects, I was so busy helping put together the tools to really support our practice from the EHR perspective and core med management supporting solutions. I think specialty pharmacy occurred around me versus actually having the needed insight that as it was evolving, given I was busy doing so many things. I actually recall when scoping our EHR initiative, one of our specialty pharmacy end users asked me, "What are we doing to support the specialty pharmacy practice?" And a light bulb went on, and I was like, "Oh, I guess we're going to need to add that to our scope." So, anyways, I think what we've really seen is that this, especially pharmaceuticals, have really emerged as kind of the fastest growing segment of the pharmacy industry. Obviously, dominating new drug development in the past decade. What I see is essentially that especially pharmaceuticals represent somewhere around 50% of all of our expenditures, and increasing percentage of our revenue, somewhere around 40 or even 50%. So I've seen obviously drug prices continuing to grow, and the shifting and consolidation of the specialty pharmacy practice has also occurred as with that. So I think we're moving as we identify and see health systems starting to look at this as a potential revenue source. The health systems are beginning to get involved in this process simply because many of these therapies, expensive therapies, are started in the hospital setting and continued on an ambulatory side. And what we often see is that the integrated and coordinated care that we provide as part of a health system, we're able to deliver that more effectively and in a higher quality. So again, as hospitals and health systems continue to operate within margins, we're really looking at this as another revenue source for us. And that's kind of one of the things that I've seen more and more as this practice evolves.
I would jump in and say the change has been remarkable in this sector. I would almost attribute specialty medication to why I became a rheumatologist, Andrew. When I graduated medical school 20 years ago, a lot of people equated a rheumatologist with an internist, some joint pain, let's do some aspirin, let's do some NSAIDs, non-steroidal anti-inflammatories, and, follow the patient. And then there was just the birth of science, of advancement in medication, cytokines, understanding immunotherapy. And all of a sudden I said, I want to be part of that. And started small, one or two medications. For those of you who may be familiar with the Enbrel, Humira, tumor necrosis factor inhibitors, started very small. And now, the therapeutic interventions affordable from a decision standpoint, a shared decision making with our patients are vast. And it's changing even further in the sense that it's not just injectable medications or infusion therapy. We have oral therapeutics coming forward in this arena. And it's a very exciting time, not just as a clinician, but very exciting for our patients as well. And that's where I stepped into rheumatology to really watch and participate in what I see as a complete overhaul and improved outcomes for people with chronic diseases.
Yeah, I would jump in and just echo that. So, oncology is replete with this explosion of innovation, targeted therapies, immunotherapy, truly game-changing, being able to talk to stage 4 solid tumor patients about long-term, we really hesitate to use the word cure, but long-term remissions. And so that's this wonderful explosion of innovation. I'll never forget, as a fellow in the early 2000s, my career has kind of tracked with this. I had a patient in my fellows clinic that had been on one of the original clinical trials for a medication called imatinib, which is just probably the single best example of a rationally designed targeted therapy that has just changed people's lives and saved lives. So it's been a story that really drew me to oncology and I've loved. At the same time, It's incredibly complex from a purely clinical standpoint, but we've alluded to the costs and some of the infrastructure. Our ability to deal with that at the point of care has either lagged a bit, or we just haven't been able to totally get ahead of it. And so in addition to taking care of the patient and doing the clinical care and the patient's challenging enough experience to be dealing with a terrible illness, there's this other layer of actually executing on their care and delivering these medications, both oral and infusional, that, we got work to do on. So I'm excited, to have conversations like this.
Yeah, I would add that there are a number of unique requirements around these medicines. I think all of us are, clearly experience that, and I tend to get involved with helping our providers overcome a lot of these things from a technology perspective. There are many unique fulfillment elements that are included as part of prescribing these medicines. There's a number of technical and clinical patient care support services that we have to include as part of their care coordination and that sort of thing, and follow-up. And then, there's just a number of other characteristics of a specialty pharmacy medicine that we're all obviously well aware of, that doesn't necessarily always include just the high cost in special handling, storage, delivery, all kinds of REMS-related activity that needs to be fulfilled as part of FDA requirements. So there's a lot of unique characteristics of these medicines that, again, add to the administrative burden and clerical burden on our providers. That is extremely challenging.
For me personally, I've seen this transformation when I was in medical school, maybe a little bit before Ilana. The decisions were easier and straightforward. I just thought of, the medication and gave a prescription and didn't really think about it before. But now with this complexity, there's so much that a physician has to think about at the point of care, not just that decision of, I made a diagnosis, now here's the best therapy, but many, many other factors. So I'll start with you, Ilana. As you're in the exam room with a patient, or as a rheumatologist is in the exam room, what are you thinking beyond just what's, even now it's more complicated, but what's the right drug, and what are the other things you're thinking about?
It's a great question. So certainly we're looking at the patient and the unique past medical history that the patient has. That's top of mind, allergies, family history, all of that comes into the clinical decision process. Of course, we need to look at any prior interventions and if the patient failed those therapies. And then you come to where the rubber meets the road and you say, okay, in your case, you have, for example, rheumatoid arthritis. You have, unfortunately, already tried some traditional disease-modifying anti-rheumatic drugs, and we need to proceed with a specialty medication. It's the next tier of medication. And you start to explain the complexity, and patients are used to taking perhaps an oral medication daily or weekly, and now you start the complexity, this is administered by injection. And then, patients may get leery right off the bat. Subsequently, you're trying to explain which medication you're interested in initiating with the patient, but in the back of your mind, there's so many questions. Well, what insurance does this patient have? What is on formulary? What will be covered? What will be the patient portion of responsibility with respect to cost? And that's where things get very difficult. And many times when I discuss Andrew therapies, I try to discuss them in a general classification because I'm not sure which of the items will be approved, and that's a dynamic target. Many times on an insurance, maybe January 1, there's a different pharmaceutical that is top tier in terms of availability for the patient and affordability. So I don't want to give a particular name because the patient may get very concerned if the insurance doesn't authorize that name, and now I want a different one. Is it not as good? So the long and short of it is it's complicated. My goal is always to explain to the patients the risk-benefit reward of starting one of these medications and taking their personal medical history into account. And then again, it's going to be several days or weeks till we get perhaps all the items, paperwork, patient assistance squared away. And many times right at the point of care, I can't make that claim right then and there for the patient. This is what you will be starting. This is when you will be starting it. It's more a discussion and say, let's wait and see. Don't be worried. This may take a little bit of time. We will figure it out and we will keep you informed along the way.
And you know, from my perspective, this is, again, I'm supporting a large specialty practice at the Mayo Clinic, and as you just described, and because of what you just described, it's not uncommon for patients to experience significant interruptions in therapy or even delayed starts of therapy. And the current system that you just described really speaks to both the high abandonment rates in suboptimal, medication coordination resulting in poor adherence, and that's what we see consistently because of that clerical burden that you alluded to. It just again, my approach in doing all of this for our specialty practice physicians is I want it to go away, make it go away for them, and that's simply the approach that I use. It sounds virtually impossible, but yet that's where we need to get. They spend a great deal of time deciding and researching the most appropriate therapy for that patient they're having that encounter with. And at that point in time, I give them all the credit in the world in terms of that research, that individualized treatment and therapy. All the rest should just go away. So that's our approach.
Yeah, I think what's going through my head in the exam room is trying to be sensitive to the patient experience, because you just remember that, especially new patients, new cancer patients, after you've had a line or two of chemo, maybe you become a bit of a veteran and you understand how this works and some of the craziness that you may see from a patient perspective and just getting the care you want. But especially new patients, they don't live in this world where they I think they come in thinking my doctor is going to select a treatment. I'm going to walk out knowing what that is. It's going to be a fairly seamless experience to get that. And then I'm on to my major issue, which is fighting this terrible cancer. And so trying to be sensitive to that in the exam room, if you can't be sure that the therapy that you think is best for this patient is going to be approved, it has real implications as well for their care. So for instance, for certain things, they need to have a port placed, an implanted device to get IV chemotherapy. Well, I can't snap my fingers and make that happen. So if one therapy does or doesn't get approved, I may have to get a referral into a surgeon and have an outpatient procedure, which is an enormous deal for a patient. I may need to order a cardiac test to make sure for certain drugs that their heart's working. So all of these things net out to potential delays in care and in some degree, possibly an undermining of confidence in the whole system. And when you recall that there's a patient at the end of this that is usually very afraid and has usually, lost a lot of the autonomy that we enjoy when we're healthy, that's a big deal. So with my prescribing hat on, I'm trying to be sensitive to that experience and make sure that there are no more surprises for the patient than there need to be. I always feel badly when I say, hey, by the way, we can't start you Monday like we had hoped. In fact, now I need to get you into the surgeon to get a port. And, that can be disconcerting for the patient.
Yeah, let's drill into that patient a little, the patient perspective more. Ilana, I know, I'm sure in your most reassuring voice you'll say, don't worry, in your most reassuring way, but I think all of us know who've been patients. It's really hard not to worry when you've just met with your doctor. And James, as you mentioned, you're in these incredibly emotionally charged situations, probably for many people the most vulnerable moment of their entire life. And so, you've talked a little bit about this, but let's drill a little deeper. What do you think is going on in a patient's head during these conversations? What are they worrying about? What are the challenges that they're going to face in the journey? I mean, how are they perceiving, as best as you can tell, that conversation?
I mean, I think that, with a cancer diagnosis, really the biggest thing they're worried about is, am I going to die of this and when? And, so bring it back. If you don't, we're doctors and healthcare people, but coming in newly diagnosed with cancer, am I getting care from a place that is able to give me the best chance of living or living longer or living better? And I expect these wrinkles to be ironed out, and if they aren't, that's just another added source of anxiety. And so I think they want to come away with an understanding of their disease, an understanding of their goals of care, and an understanding of the next tangible steps that they can do to get on that journey. And so often that is either picking up a medication and being able to walk away from the pharmacy and start taking it as directed, or, sitting in a chair in an infusion center and getting an infusional therapy. And so patients, I think a lot of people understand the cost of healthcare. That's been a big enough issue in our society, and it's probably not a shock that some of these medicines are expensive, although there is sticker shock. And so, I think it's really important to remember that you want the patient to have the resources that they need to navigate patient assistance, so they can make sure they don't walk up to a window and be told they can't have their medication unless they produce, a suitcase full of cash. And you want to make sure that when they do go down the journey, the prior auth / patient assistance journey, that it's not, this really painful experience for them that adds a lot of stress to their life and undermines their confidence in the process. So trying to be sensitive of that and get ahead of those roadblocks that will likely be there is an important. That's what community cancer clinics have to spend a lot of resources on doing.
I think giving a realistic timeline is also very important. I tend to err on the side of longer than shorter turnaround times, so people could be pleasantly surprised if something does get approved rapidly. I'm usually surprised. And, I agree with Mark if there's a way to, eradicate all of this back and forth and just make your decision and get that in the hands of the patient within 48 to 72 hours, that's the dream. But I do try to indicate that it's a process, because there is a lot of back and forth in this. Sometimes it has to go to a level of an appeal, and that takes time. And some institutions and payers have 30 days with an appeal process, for example. So I try to just indicate, and there's paperwork that may need to be filled out. They may need to allocate myself as a representative allowed to do an appeal, etc. So there's back and forth, and the timeline can be long. And that's where it goes to what Mark said about abandonment, is I just try to give some realistic expectations, because if people think they haven't heard back from your office in 48 hours, then, maybe this wasn't for me. And maybe this doctor, maybe I need a second opinion. And of course, now everybody wants things, instant gratification, immediately delivered to their door within 48 hours on Prime, for example, of Amazon. And with this process, it is not rapid. So we have to just level set on that expectation and indicate that this doesn't mean that you shouldn't go on this medication if it takes long to authorize. But that's the window where individuals start talking with neighbors and internet and blogging, and it gets very complicated for the physician, for their staff trying to authorize it, and for the poor patients, like James said, that are navigating a new disease diagnosis.
Yeah, this, Mark, I would agree, and those of us that have worked in the acute care setting clearly understand the the difficulties and transitions of care as they go from an ICU setting to the general care floor and then out the door. This is very similar, and I think coordinated, integrated care is extremely important, particularly as it relates to all the transitions that need to take place around a specialty medicine. And I think even in our organization, we're very optimistic that specialty pharmacies owned by health system will show benefit, simply because they can provide that coordinated care. Just, I mean, face to facts, when I get up in the morning, I want to call my health insurer, right? I mean, that's the last thing I want to do. I want to be able to follow up with somebody I know, particularly as it relates to a medicine that's extremely expensive, difficult to get, and is for a very complex disease or treatment that I need and is recognized by my provider. So again, I think there are many health systems are getting into this environment, although it's still going to be a struggle. But I think, again, to my point about the integrated and coordinated care for this type of medicine is extremely valuable and important, and health systems are positioned to do that.
I totally agree. I mean, in the oncology, we're prescribed a fraction of chemotherapies. Having a lack of visibility into adherence and getting their refill, picking it up on time, that impacts care. And Mark, I would completely second what you say. These are high stakes medicines. You know, there's life and death, there's major side effects, there's a huge cost. And small things matter in terms of that coordination of care. And so you really, you shouldn't have to do a lot of work to have the information you need in front of you to understand what's going on with the patient. And if that means keeping the specialty pharmacy in the practice or in the health system, then it's very plausible that actually impacts outcomes enormously. And I think that's what you see play out in the real world.
Yeah, that's a good transition.
Yeah, I was just going to say the economies of scale that you might be able to achieve, I think you have to scratch your head and say, at what cost? It's an important way to look at it from a system standpoint.
Actually, that's even a better transition. I was going to ask for my next question is, there is a big cost and a big burden on organizations as they're trying to smooth that journey for the patients. I know, for example, Mark, I've talked with you, I've had a chance to see some of your operations, and you've put a lot of infrastructure in place to help support that patient journey, to help smooth things out, to help get them on that therapy that the doctor ordered. Talk about what organizations, what your organization, what other organizations are doing to invest, to build infrastructure, to create tools to help smooth out these processes and really shield the patient from some of the challenges that exist on that journey today.
Yeah, that's a great question. And again, part of our work within our organization, and again, is given the provider doing the research and really selecting an individualized treatment for a specific patient, all the other work that goes around and the burden that goes around to making that happen is, again, our so that our specialty practice can see more patients, can provide more care, specialty care. We need to make sure that stuff goes away and is managed effectively. I think, some of the biggest challenges obviously are given the complexity, there's a word that I often use is our software vendors need to deal with complexability. The system needs to be developed around and be flexible enough to manage all the complexity. And with that, I think we find that the solutions are very broadly determined, and oftentimes they're not necessarily tailored to the specific needs of, any individual patient or practice. I mean, here on this call, we have somebody from rheumatology and oncology, and again, their needs and their specialty types of medicines may be completely different, handled different, priced different, all different kinds of things that would affect the development of the tools that you have to support those practices. So my guess is we continue to work with our vendors, primarily our EHR vendors, to really help manage that, as I call it, complexability, so that we can tailor the tools to meet the practice needs. And at the end of the day, I think our best solutions are going to be more, as I see coming down the road here, is some things that could essentially, either through natural language processing, AI, being able to go out and find the necessary elements that are required to meet the regulatory requirements and compliance requirements and REMS requirements, so that we don't necessarily have to continue to hide administrative roles or continue to grow our administrative roles while keeping our physician community at the same rate while we keep asking them to do more. And again, I think that overall clerical burden, our physician burnout rates, I'm actively involved in making sure that, that status quo has to change. Again, growing number of administrative functions, 35 to 55, 60% of our U.S. physicians feel burnout. Manual processes are still high. I mean, I know we have the 21st Century Cures Act that's really looked at reducing clerical burden, but we have to improve usability, workflow integration, interoperation, and without those things, without seamless interoperation, again, we're going to continue to struggle. So I'll stop there and be interested in hearing what my physician colleagues think as well.
I would say amen to that. Yeah, I mean, it's real. I think, I do see some signs of hope. I think that a lot of the manual processes, especially related to prior auth, I don't really think anyone likes those. One of the things that we have thought about in terms of using technology, which kind of layers on top of what you're saying, is a lot of times I think one of the reasons that a lot of the medications that get ordered wind up getting authorized, even though there may be a lot of pushback and a lot of back and forth, is that the doctor actually knows. Now, I'm biased, I'm a doctor, but they have it up here why they are ordering for this medication for this patient. And part of the delay, let's give everyone the benefit of the doubt and say part of the delay is effectively establishing the communication between the physician and the authorizing entity to communicate that. And so, I do think that's a completely manual process now. Very few things in the specialty world get a quick semi-auto authorization, even though they probably could. And I think there are too many peer-to-peers still and too much back and forth. So is there a way, if you think about the having your software's workflow, think like a doctor and capture as a byproduct of my clinical decision and shared decision-making with a patient and ordering those data elements that can be transferred electronically to the adjudicating agency, can we increase the number of real-time or near real-time authorizations so that very quickly the doctor, the patient, and everyone can know that the therapy is authorized? Can we minimize the number of back and forth human interactions? And I think there's appetite for that on both sides, because I think there is a lot of spend happening on both sides. What comes with that are things like standardization. let's think about the data elements that are really required to make sure this is the best medicine for this patient. And then, of course, the whole, there is legislation working on increasing interoperability standards to allow diverse systems to talk to each other so this sort of electronic handshake can happen. So that's reason for optimism. That's how I spend some of my time with my technology hat on. I think there are real solutions there, but there's also a lot of work to be done to get us from here to there.
I would agree. I would say most offices have entire back offices with dozens of people full-time manually handling these items. They're manually handling paperwork and filling out forms. And I think it's going to be a great challenge, but a great opportunity to leverage technology to help streamline this and reduce physician burden that you mentioned, Mark, and patient anxiety while they await the process.
Yeah, I mean, so much gets spent on staff to do this manual prior auth piece that could be repurposed to more things that actually deliver value for the patient.
Yeah, we need more physicians. We don't need more administrators. We have armies.
Yeah.
Our organization, we have an army of people. I think Andrew has seen some of those, but we have armies and armies of people on the backside taking care of these things, and all that expense is transferred someplace, right? I mean, it's
right.
None of it is free. So we have to do better at creating solutions, standards, leveraging our technology to do a better job at reducing some of that. And I think one of the things we forget is that we still have a huge medication spend with suboptimal outcomes, no matter where we look or return, whether it be adherence, abandonment rates, just people unable to afford adverse outcomes. We have so much work to do. That's the work our providers and our clinicians need to do. This other stuff it doesn't really help improve some of those suboptimal medication outcomes that we see every day.
And in some ways, it actually blocks. I mean, adherence is super hard to get insight into when you can't figure out whether and when they got their medication, and it's the whole sort of black box piece of it is really detrimental to having the data to make better decisions on those.
Yeah, so we have time for one last question, and I want to just build off of what we just heard. There are a lot of challenges today. There's a lot of administrative costs, challenges around adherence, challenges for the physicians and patients. So to me, what's really unique about this symposium that we have today is we have representatives from literally every key stakeholder, every key person and role that plays a part in that patient's journey for specialty medications. Pharmacies, life sciences, pharmacy benefit managers, other insurance companies, technology vendors, patients, providers. Everyone is listening on this call and participating. So from your individual perspectives, what is your sort of one thing you would tell this diverse group? What are the things that we together could collaborate on, focus on, catalyze, drive that change so we're creating a much better experience ultimately for that patient and their journey? How do we remap that journey from that incredibly convoluted and complex and worrisome journey filled with potholes to one that's smooth and goes from the physician's brain to the start of therapy? So, James, let's just start with you for that one.
Yeah, so I think if there were one thing, it would be that standard, and I'm speaking from the standpoint of a technology vendor, but it would be embrace standardization and think about, before you build a very bespoke piece of your own portal for prior auth or for patient assistance or whatever, think about whether it could be boiled down to some standard elements that really matter the most. And I say that the same way, you know, in the oncology EHR space, there's an effort underway to standardize some of the data elements that we capture, and that's really important work too, because that underpins a lot of the ability to automate some of the things we talked about, that, you know, to automate the exchange of data and the communication that allows the patient to get the right treatment. So embrace standardization. It may be painful up front, but it will likely pay off through more efficient care delivery in the back end. And that, you know, finding that alignment with these specialty medications, they get better outcomes. And so whether you're a payer or a patient or a doctor, that's what you want. So indexing on that alignment and trying to get people to standardize so we can communicate.
I would agree. I think anything we can do to capture granular items that are standard, that can automate and auto-populate, we're going to reduce technical burden. I would also like to say that one of the great things about the pandemic has been the acceptance of the patient portal. And I would say that more patients are becoming active participants in their own care and leveraging technology from the patient engagement side. And I think it's going to be upon us as well in the technology space to look at that piece and bring it in, because I have a lot of patients at the specialty authorization moment. They say, well, what can I do, doc? Who should I call? How can I move this along? Anything you need from me? And again, if we leverage the opportunity for patients to participate at the portal level or be in communication and collaborate, I think that will also assist dramatically. So I'm very excited to look at that as well, not just to automate the physician workflow, but also to help us leverage patient engagement.
Yeah, and I would just add on to that is that, you know, how do we optimize the value that the provider brings in making a therapeutic decision that is really optimal for that, you know, that patient that they're seeing. And we need to reduce anything that would suboptimize, you know, those decisions, and utilize the tools and technologies that we have. And we could certainly need to ask the question is, why do we have 20-30% of prescriptions are never filled? What's the reason for that? Where's the coordination and the follow-up to really get into that? Why do we have so many ED visits from adverse drug events? Again, why do we have so many hospitalizations related to adverse drug events? And then again, loss of medications revenue due to just non-adherence. So I think anything we could do to optimize that medication selection and choice outcome, and the infrastructure we provide to do that is going to lead to success and reduce our overall medication spend as it relates to these outcomes.
That's great. So I know we're just about at time. I really want to thank our panelists. I learned a ton on this. You know, Mark, I love the word complexibility. I may steal it from you. Ilana, I really, you know, it's really helpful for me to hear how you approach, as a physician, what's going on in your mind as you're talking to the patient. And James, I mean, I know you have this incredible sort of moment with the patients where they're hearing their first cancer diagnosis. And listening to you, that sort of how you perceive that burden of that diagnosis and your role in trying to make that as smooth as possible for them. A lot for me to think about, a lot I've learned. I really want to thank all three of you for your taking the time today, for sharing these insights. And most importantly, for the audience, I hope this isn't the end of this dialogue. I hope this is something that, again, is starting to catalyze change for standardization, change for better patient engagement, change for helping the physician reduce that complexity and focus on the clinical needs of the patient. So again, thank you for your time today. And
Thank you.
Thank you.
Thank you so much. Yep. Great.
All right. Well, before I turn this over to Mike for some closing comments, just a few things from me. First, I really want to thank our speakers today. They shared incredible insights, things I'm going to be thinking about for a long time, and I hope you're going to be thinking about this too. Second thing is just administrative details. You will all receive an email next week. There'll be a survey in there. Please take a moment to fill that out. We'd love to hear your thoughts. Again, you can still email us at specialtysymposium@surescripts.com if you have any other thoughts or ideas or want to talk more about what we learned today. And the recordings will be up next week. And last, I hope all of you are not leaving today just saying, boy, that was interesting, or I learned a lot. But you're thinking about how can we remap that journey? To me, what struck me about this conversation today, what I heard from the speakers, is I don't think I heard of a single problem, a single item that can be solved in a silo. Nothing that can be solved just with one business or one organization. Everything we learned, we can only solve by collaborating together, by working together, by remapping that patient journey, and most important, keeping that patient front and center so they're spending their precious personal resources only on healing. So I'd like to turn this over to Mike Pritts again for some closing comments.
Thank you, Andrew. Very well said. And thank you to all of our engaging speakers today. Hearing from so many experts is a very rare opportunity, and I learned a lot. Since this morning, I've also had some time to think about that upcoming trip to Charleston. And while I'm delighted to know that I've got a simple and accurate means right here in my hand to guide me there, Charleston. About traffic, there it is. I've reflected on what I heard today. And it's easy for us to all, I think it's easy for us all to agree, we've got a long way to go to get the specialty prescribing process anywhere close. Prescribing specialty medications needs this same kind of transformation. Stephanie Stern set the stage, telling her story about the unending ping pong match she must play just to get her mom her medications. I don't know about all of you, but I don't want to have to be an Olympic ping pong player just to get my meds. Nor do the 1 million MS patients she spoke about. Wendy Bailey so eloquently spoke about amazing gene therapies that are truly revolutionary, but also the waste that often occurs and where technology can save the day. And Brian Bamberger told us about all the wonderful medications filling manufacturers' pipelines and the need to remove routine friction that slows the process, getting these remarkable therapies to patients. But as you also heard today, transformation is rapidly occurring, and that's great news. Joe Helly shared just how just a few years ago, their pharmacies were still sending and receiving 50-page faxes. I honestly can't even imagine. 50 pages, I count it myself. I can't get my printer to send even 1 page without issues. But with various innovations, Joel also expressed how much better it is today with digital exchange on the rise, faster fill times, and greater convenience, all leading to better adherence. That's real progress. Jeff Spafford showed us the complexities of the entire ecosystem and where sophisticated automation and workflow engines are flipping traditional hub models on their head. And wrapping us up, we heard an esteemed panel of providers share very concrete experiences about the challenges they and their patients face every day on the ground. And Mark Siska asking us, just please make it go away. Yet still expressing optimism about the help they see on the way, and more is needed. Surescripts has always seen our role as a convener to solve big problems. We've been doing that for 20 years. The specialty medications journey is a big challenge and an even bigger opportunity. Innovation is here, and now is the time to use that innovation to cure this problem. It's a big task, and one that every single person and organization here today plays a role in solving. And Surescripts is honored to connect with you and help steward these innovations together. Thank you for your time, your expertise, and your engagement. We can and we must streamline the specialty prescribing process. Prescribers, pharmacists, family members, and especially patients like Stephanie's mom are counting on us. Thank you.